See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
Welcome to See You Now. I'm Shauna Butler.
How do you change a number of discrete events that happen very apart in time? How do you change that experience of care to a more continuous care where people feel cared for?
So what do? We collect this data, and then our algorithms really process it in order to drive behavioral insights. And the power of behavioral insight is that it answers all of those questions you had, like, when should I call mom to check in on her? We should get her an aide for 3 or 4 hours a day for a few days a week. When should that aide really go to the home? What we're trying to do is really connect people.
Across the globe, millions of people are experiencing the challenges, complexities, and costs of caring for elderly family members. Challenges that have been amplified and complicated by the coronavirus pandemic, and challenges that are well suited to technology and data solutions and in desperate need of innovation. Fortunately, there is a growing international, interdisciplinary, and intergenerational community of innovators addressing the challenges of aging, managing chronic diseases, and the need to do it remotely, continuously, and seamlessly. In this episode, we meet Joshua Littlejohn and Gabriela Sabaté, two health innovators who are experimenting and innovating with technologies that connect data to transform how we not only provide care remotely, but how we can crowdsource the ideas and teams to innovate and hack health.
Hi, my name is Joshua Littlejohn. I'm head of product for Envoy at Home, a startup here in Philadelphia, focusing on connecting older individuals aging in place with their loved ones and professional caregivers through data. I'm also an innovator, entrepreneur, and nurse. I work for the University of Pennsylvania Health System in the Data Analytics Center as a product owner as well.
I'm Gabriela Sabaté, and I'm a digital health entrepreneur, executive, and investor. I founded and currently lead Health Semantics and also Cludy to address the prevention of chronic conditions like diabetes, hypertension, and obesity. And we do this through a software platform and data insights that include innovative care delivery models and telemedicine. I also worked in IBM and venture capital and in SoftBank.
We actually got connected through two different avenues. The first being hackathons, specifically the MIT COVID-19 Challenge series of hackathons. And then secondly, through the Society for Healthcare Innovation. And we've since been cooking up all kinds of plans and ideas, hatching schemes in order to take advantage of our current innovation climate that healthcare is being forced to go through via COVID.
Both of you have this fascinating, and I will say a healthy obsession, maybe bordering over towards addiction a little bit, for solving the toughest healthcare problems. How do you end up having this really strong drive to be a health innovator?
I think that I've been an innovator and I would say an entrepreneur, but also an intrapreneur most of my life. So originally I come from the tech industry and from the engineering school as a base. So the fascination with innovation comes from, I would say, the origin, even when I didn't even know the words, or that what I was doing was innovation, was called innovation. So also I come from a family of doctors and physicians, and my dad was a doctor. He co-founded a hospital in Argentina. So that also runs deep in my heart. And at one point I had gone through so many phases in the tech industry and the innovation in tech that I decided that it was time that I applied this to another passion of mine, which is transforming healthcare.
Well, you do have an interesting pathway into health innovation. We don't always see people with the technology, the engineering, and the venture background coming to play in our sandbox. I think, Joshua, you have a very healthy appetite as well for solving some very difficult challenges in our healthcare system. Where'd you get this appetite from? And part of that is like, what's your background as far as feeling capable and prepared to take that challenge on?
I'm a second degree nursing professional. My first undergraduate degree was in molecular microbiology with a minor in Spanish, very research focused.
Yeah, when we
Sure.
say second degree nursing professional, what does that mean?
So second degree nursing professionals, and there are many of these programs that are coming up mostly to address issues of workforce capacity, essentially.
Well, caregiving and the shortage of people providing it is enormous.
Right? It sounds like the impact on society is the real big challenge. Let me tell you, it is not the impact on society. It is the how do you change the system within which you work, because healthcare is so large and so complex and so regulated that change is very difficult.
There was already a caregiver crisis before the pandemic hit, where we were looking at an aging population or people with chronic conditions needing help in rural areas, at homes, in nursing homes. We didn't have enough to go around at that point. And then when you layer a pandemic on top of that, it adds multiple sets of challenges between isolation, preventing the transmission of the disease, of any disease, but in particular one that doesn't have a vaccine or a therapeutic defined for it, and we're seeing can be lethal. Joshua, can you explain your current role, or roles is probably a better way to put it. Why don't you start with your current roles, and then I want to have you share some thoughts that you have on this caregiver crisis and what you're working on about that.
So I'm head of product for a Philadelphia-based startup company, Envoy at Home, in the health tech/age tech area. We, in our simplest form, our technology relies on sort of remote sensing, but we are far more than remote sensing, using data to drive our decision-making around care planning for older individuals who really want to age in place.
I want you to break that down for me. So the first thing you said is head of product. What does that mean, head of product?
It means a number of different things. There's product management and product ownership. So I have another role where I'm a product owner, which is more of a technical aspect. They are the connector of the dots between the technology, between the business, and between the engineers or whoever is building that technology. They're really the voice of the customer. And you can kind of see how a nurse would be very well suited for a product role. Why? Because think of nurses and the role that they play in the care team. They're between the family, they're between the patient and the doctor and the technologies.
So head of product, doing remote sensing, pulling data in so that we can provide care. Those are all really great words. What does that look like in practice?
So I'll start with something that people may be more familiar with, and that's telehealth, right? So telehealth, the reason why I'm going for that sort of metaphor first, or that example first, is because we're in times of COVID where, literally entire hospital systems have reduced volumes of elective surgeries down to to nothing in some cases, and then have slowly ramped back up. What took its place was really telehealth and the ability to provide care from a distance enabled through technology. So your laptop or a scale that's connected to some sort of Wi-Fi receiver that transmits that information somewhere else. And patients, particularly this year, are a little bit more familiar with that. But what happens after that? Well, what does that mean? All right, so I stood on a scale and I took my blood pressure and it went somewhere and did, the data went somewhere and did something. It sort of stops there for many people. The other part of that is it could be connected to an EICU where you have a number of nurses and doctors looking at these vitals on a regular basis to identify high-risk individuals. It could be connected to a family caregiver or trusted other. And so some of these platforms, such as Envoy, actually, again, they're doing that one step extra, which is providing the communication not just to the professional caregiver, which for many patients is like a black hole until that professional reaches back out to the family or the care recipient. What we're trying to do is really connect people. So when we talk about remote sensing, it has many shapes and many flavors. But I think that as we move forward, we'll see enhanced capabilities through things like machine learning and AI layered on top of basic data gathering applications.
Well, how does that translate into a family? So you've got a 52-year-old mom. She's got 3 kids at home. She's trying to homeschool them, and she has an 87-year-old mother and a 94-year-old father who live 2 states away. And she is concerned about managing their chronic conditions. How does Envoy at Home be that solution that helps to solve that geographic gap, that time zone gap? And truthfully, I think for most of the folks that I talk with who are helping to take care of aging parents, it's a time gap. I just don't have enough time to give them the care that they need, pay attention to them, and I don't know when they need me, and I don't know what they need.
The first thing I do want to say is that we are designed for really older individuals who live alone, because those, in our mind, those were the individuals that were highest at highest risk for something happening and nobody to be there to know anything until maybe hours or even worst case days later. But one of our co-founders essentially is doing exactly what you described. He is caring for his mother who lives in Florida and he lives in New Jersey. The question became, how do I stay in contact with mom and know on an urgent basis that something has happened on? And so he, being an engineer with our CTO, who is many, many years in database administration, put together a hardware package combined with this software package on the back end and gave birth to Envoy at Home. So there's at least 14 million individuals within the United States that are elderly and living alone. The issue of elder orphans, or maybe not even elder orphans whose families said they've outlived all of their families and friends. It is a very unique and sometimes unfortunate situation in that they are the last and they don't have all of their support network. Or individuals who, as you've pointed out, simply just live down the street in another state, in another country. The point is they don't live with somebody. So what do? We collect this data and then our algorithms really process it in order to drive behavioral insights. And the power of behavioral insight is that it answers all of these questions you had, like, when should I call mom to check in on her? We should get her an aide for 3 or 4 hours a day for a few days a week. When should that aide really go to the home? Of course, you would have a conversation with mom in order to get preferences, but perhaps you thought that mom went to bed at 9 p.m. every night, and really turns out mom's up, until 2 a.m., 2:30.
Gabriela, you share a very similar interest in taking a look at remote care, remote sensing, and you have an interesting lens on that as your role as founder and CEO of Health Semantics.
Health Semantics, yes. We founded Health Semantics, and I founded Health Semantics to develop a platform that would help heal or help prevent chronic diseases. When Joshua was mentioning remote sensing, it also drives me to, it's the world of sensors exploding. And with the world of sensors, it's the world of Internet of Things. You can apply those sensors to specific use cases within healthcare. Then there's another area, which is all the omics, like genomics and transcriptomics and metabolomics and microbiome. So such big numbers, such big data. No, so big data meeting big medicine in the end. And right now, at this moment in time of our tech evolution or development as a global development, we're living in this intersection where all of this is beginning to be possible in a very cost-effective way. Be able to process all that information about someone. All the genomics, all the layers of information, all the history, everything about one particular person, but also about a population. So layering, going to your question of remote sensing and what Joshua mentioned about remote sensing, it is exactly that. So when I think of these big visions, that is a vision that really is one of the passions that moved me to healthcare. Coming from whichever profession we come, be it a clinician, a nurse, a physician, an assistant, an IT person, an entrepreneur, there's always all these winding paths allow now for joining those different fields of knowledge. We also work to innovate in different care delivery models, close to pharmacies.
Let's break that down, because we use that term a lot, care delivery model. Okay.
Yes.
So what is a care delivery model? And then what do you What do you change? What is health semantics changing about that?
That's an area of innovation that I'm particularly interested in, which is getting care out of the traditional places. Like we're used to going to the doctor's office, we're used to going to a hospital and get care in a hospital, and that is more or less could sum it up. So what if care meets the patient? There's a number of different ways that healthcare can be delivered to the person. And so instead of our thinking around a hospital or around a doctor or around a doctor's office, we are starting to think more around a person. And right now with the pandemic, our world has been like made smaller in a sense. But at the same time, there has been, I think, a big acceleration in the knowledge production that has been something that at least I had never experienced before. Having so many different groups of technologists, researchers, scientists, doctors, nurses, all working together, trying to understand what is this person needing, what are their circumstances, where do they prefer to get the care. And it's not necessarily using half of their day to go visit a doctor or necessarily go to the ED, which on top of being
that's the last place we want them to go.
Expensive, exactly. On top of being extremely expensive as a society, it's not a continuous care. So these are alternative care delivery pathways or ways.
So you're thinking about like providing care or being available. It's not even providing care, but being available in a grocery store, in a church, at a local park, at a school, at a workplace, any of those types of...
Exactly. Or a mobile clinic that can move around and visit your town if you have if you're situated in a remote place outside of or very far away from a big city where, or you're in one of those health deserts where there are no services available. So perhaps you can receive services through a mix of ways. But the challenge is...
It's not binary.
Exactly. It's not binary. It's a continuum. And I say this a lot in health semantics. No, it's how do you change a number of discrete events that happen very apart in time? How do you change that experience of care from a number of discrete events with nothing in between to a more continuous care where people are feel cared for? And it's not the whole burden of, if you go for just a checkup is one thing. If you have a disease, it's a lot of burden to take care or to the administration of the disease. Calling doctors or nurses or hospitals all the time,
lab work, physical
lab
therapy.
work, and getting all those appointments, and then dealing with the bills. One thing is to have a yearly checkup, and you're a healthy person. But if you have a condition, then all of a sudden you have to become a professional of that condition and be in charge on top of having the condition and dealing with the lack of health or the condition, the disease.
Gabriela and Joshua are working to solve some of the most challenging and complex problems in healthcare. And as we've been discussing, they're already far along in their careers, working with some of the best teams to address certain facets of our global caregiving crisis. But they didn't get there by working alone. They have been able to build multidisciplinary teams in order to pinpoint problems and work toward affordable, far-reaching, and inclusive solutions. That's how hackathons can play an important role. Hackathons, which are a form of a design sprint, bring together a number of different individuals from a wide variety of backgrounds, experience, and skills to convene over a short period of time, often just 72 hours, to solve a focused problem. The keys to making this work are the short time limits and the variety of people. Individuals form teams who then quickly identify the problem they're trying to solve, then iterate rapidly to come up with a viable solution and a pitch describing the solution they've developed. But the magic comes from the varied perspectives that each teammate brings to the problem. If you are the care professional, you have a different relationship to the problem than the person experiencing it. If you're an engineer designing a solution, you're going to see the problem through a different lens than, say, an investor. It is in working together, sharing tools, learning different technical languages, and building relationships that hackathons provide a unique space where innovation thrives. Hackathons are a rich resource of discovery, places where you'll often overhear teams say things like, "Wow, I had no idea that was a problem. I never would have thought of that." They bring a new group of people together with a shared purpose. They help to increase innovation skills, surface hard-to-discover problems, and democratize problem-solving and innovation. In May of 2020, the Nurse Hack for Health COVID-19 virtual hackathon convened over 900 participants, many of whom were nurses, from all over the world to help solve COVID-19 clinical challenges in 5 specific focus areas. Joshua was part of the Project Flourish team that focused on remote patient monitoring in home care. Both Joshua and Gabriela have an enthusiasm for hackathons, for the way they support innovation and create and develop innovators and foster interdisciplinary communities. There are lots of different ways to learn how to innovate within healthcare. And Joshua, you have a wonderful relationship with hackathons, and they've worked out pretty well for you.
So the Nurse Hack for Health weekend, I actually focused on, again, home care, one of my passions, and remote sensing, another of my passions. But I wanted to address a different problem than what I typically do. And so I was thinking about this urban-rural split. My parents live in an area which, when I was growing up, was rural. Probably they still live in an unincorporated area, so it's not officially part of a town in South Carolina. My mother literally has to drive 2.5 hours to go to a specialist appointment for rheumatoid arthritis. And so that's just a facet of life in a rural context. And so the Nurse Hack for Health, I pitched the idea of, monitoring older individuals using something that was like telehealth, but did not require all of the same infrastructure that telehealth requires. And just to set the scene, telehealth requires hardware, whether it's a smartphone or a computer or something, in order to interface with another human being, and broadband internet. And
Good quality broadband internet.
Yes,
that's affordable.
Yes. Yeah. And therein lies several of the problems, right? When we're talking about 94% of the US has broadband coverage and 81% of the US residents own a smartphone. But when we start looking at older individuals who live in rural populations, 25% of rural populations lack the broadband infrastructure. They don't even have the infrastructure.
Well, and
there's
there's another really important data point on that the way that has been calculated and counted, they don't look at individual homes. And so during the pandemic, what we saw with many elderly individuals living in rural areas that have to get in their cars and drive to the library in their communities and go sit in the parking lot. Because those stats around who has broadband, it's not done on a per household basis. It's done based on a zip code and then getting into little small units. But so, yes, keep going.
Yeah, no, what you just said, the internet has become a big social determinant of health. And this has been quite apparent in this pandemic.
Yes, it definitely has. So just the last part of that, like almost half of people over 65 don't own a smartphone. So again, getting back to those two major pieces that you need in order to engage in traditional telehealth, really are not there. So our team essentially ideated around solving the remote monitoring piece without using traditional methods.
And Gabriela, you had an interesting relationship with hackathons as a mentor and as a judge. So what is it like being the mentor and somebody who's judging a competition?
Well, it's very interesting. As a mentor, throughout the hackathon, you see how the group grows and starts to collaborate. People who not necessarily have met each other before, or don't even know or share the history of who they are, what they bring to the table. So that process of discovery, it's interesting for the hackathon itself, but it's also, I think, interesting as a side effect, if you will, as a good side effect, when translating to each person's life or work situation, because hackathons also have the impact of bringing down all those barriers, all those, the secrecy between departments, all the siloed mentality thinking, no, in a time where we need to drop down those barriers.
Joshua, in addition to being in a hackathon, you organize, run, manage, host them through a relationship that you have with MIT. Can you tell us a little bit more about what's going on with MIT and the series of hackathons? I mean, there's a longstanding tradition of MIT with hacking medicine. So
Correct.
Can you fill us in on that background?
MIT itself overall has a large tradition, or a long tradition, of hackathons and hacking in general, not just in healthcare, or not just MIT Hacking Medicine, which is the organization out of MIT that has really been the behind the scenes behind the MIT COVID-19 challenge. So a little bit of a backstory. There was one of my hackathons before the Nurse Hack for Health was through MIT, which, again, MIT COVID-19 challenge, beat the pandemic. One was the event. Went through that as a participant, and then the Nurse Hack for Health. And then from there, as you say, I've switched hats to the organizer side. And since then, I think I've done 4 or 5 now. I think I'm currently planning another hackathon through the same sort of loose coalition of individuals. And the reason I say loose coalition is because MIT Hacking Medicine, while they have a tradition of in-person events and MIT Grand Hack, they were not able to do, of course, in-person events for a while. And so they took that mentality, that innovative idea around hackathons, and said, how can we do this in a virtual context? And it's actually worked out really well, because traditional hackathons are limited by space, literal space. How many people can you fit into a room, and a number of other, resource constraints.
Like the people who want to hack, can they fly there?
Exactly.
Can they afford to be there? Can they take the couple of days off? And that applies to the mentors as well as the hackers and the judges. So the going virtual has made this possible for a lot of people to participate.
Yes, exactly that. So going virtual really has it sort of democratized hackathons to the point where our events have been between 1,500 and 2,000 people generally, and they've been sourced from literally all over the world. We're not just talking about different engineers from the United States. We're talking about engineers who have different life experiences in the context of their countries, and so it's not just the different disciplines that they're bringing, but they're literally bringing different life experiences to the table. And the series of events has evolved as the COVID-19 pandemic has evolved. Our last event was in India a few weekends ago. Previous to that, it was focused on other hotspots and the unique challenges that different areas face. And so from that, the next hackathon that I am putting together is really taking that infrastructure around how do we do this in a virtual context and applying it to the other national/international conversation, which is really around racial injustices and equity. And we've chosen to focus on the topic of healthcare, so hacking racism in healthcare, as our inaugural event in that series, because the intention, again, is to create a series of hackathons that addresses structural racism in various other contexts.
The concept of racism in healthcare, we haven't approached this in the same way that we would have diabetes or smoking cessation or improving maternal health outcomes. So what's the problem statement on this?
So I think there's a number of things behind that, actually. And I think that from a physical perspective, you're right, like vaccination rates. We've been very focused on the physical part of healthcare. But I think the discipline that we're really not paying attention to here is public health, which public health has cared about this for a very long time. So the problems that we are trying to address with this hackathon they're big, they're structural, they're well ingrained in our culture and society. And so when we talk about time horizons, these are long-term projects.
We tend to focus a little bit too much on the founders and forget that it's a team effort. In a hackathon, it's a mini example of this because it's a short, a weekend designed to address a number of specific problems and come up with solutions. And there are a number of effects that I find very, very beneficial to the teams who want, to society in general, no? Like exploring the problems and getting all the knowledge, advancing, like the sharing, this exercise in sharing within a community. I think that's a very important point.
To Gabriela's point, innovation overall is a numbers game. I mean, at the end of the day, it's a numbers game. You could have 100 great ideas, but at the end of a year, for example, you may only have one of those actually come out and be ready for an accelerator or something of that nature. And that is something that the MIT group does really well. They track the progression of all of the teams that come out of all of their hackathons, all of them, and have really realized that for a hackathon or a program, given the size of what we run, we usually come out with 1 to 3 at the end of a year that are still going, continuing, have formed a company, that sort of stuff. So Gabriela's entire structure around the ways that you can support innovative ideas and approaches really struck home to me, because it is the support that makes or breaks an idea or a project, right? And so just to loop all the way back and close that circle, the hackathon, the MIT Hacking Racism Hackathon, is really focused on providing those resources to all teams, no matter if you run or if you win or not, but to all teams who feel like their solution is worthwhile. We're making the promise to continue to support you over a longer time horizon, simply because of that.
It's an ecosystem. We're building that, no? An ecosystem where seedlings can develop.
Joshua Littlejohn is a nurse with a healthy obsession for improving the delivery of home and community care using data, devices, and technology. He's the product owner of the Data Analytics Center at Penn Medicine for the University of Pennsylvania Health System. He's also the head of product at Envoy at Home, a remote monitoring system designed specifically to connect older adults aging in place with their loved ones and professional caregivers. During the inaugural Nurse Hack for Health virtual hackathon, Joshua was a member of Project Flourish, the winning team in the area of remote patient monitoring in home care that came up with a clever approach of bringing telehealth to those in remote areas. When not gathering data and gleaning insights, he's hacking for better health systems, and health outcomes with thousands of problem solvers from disciplines and time zones across the globe. Gabriela Sabaté is a technology, digital health, and biotech entrepreneur, executive, and investor, experienced in leading, creating, and operating entrepreneurial companies and new corporate businesses. She founded Health Semantics to address the prevention and treatment of chronic conditions like diabetes, hypertension, obesity, and asthma by combining sensors, remote monitoring, and innovative care delivery models. Together, they are part of the newly formed Society for Healthcare Innovation and avid contributors to the health innovation ecosystem. Each day, about 10,000 Americans celebrate their 65th birthday, placing them in the senior demographic. Research indicates that the vast majority of seniors hope to spend the remainder of their lives at home. While this trend has increased the demand for home health aides, the United States is projected to have a shortage of nearly 450,000 home health aides by 2024. While the caregiving shortage is not new, the pandemic has moved it to the top of our awareness and priority as those who are older and living alone became more isolated, vulnerable, and cut off from human contact. Frustratingly, our patchwork of caregiving solutions have not kept up with gains in longevity, changing lifestyles, more women in the workplace, and in this moment, families working from home while caring for and educating their school-age children. And now, checking in on our elder loved ones in a physically distanced fashion requires even greater creativity and innovation. COVID-19 has given new energy and urgency and surfaced unexpected collaborators in efforts to find affordable caregiving solutions many of which are data-driven and tech-enabled innovations. The pandemic has made clear that we need new solutions to the global caregiving crisis and also to several other essential services in our systems and societies. Hackathons are a great tool for problem solvers with fresh, bold, wild ideas for improving how we care for not only older people, but school children and pregnant people, for how we deliver vaccines, how we make our cities more walkable and bikeable, and as Joshua suggests, how we might address racism in healthcare. Speaking of, MIT's Hacking Racism in Healthcare is coming up October 16th with pre-event workshops on September 26th and 27th. Also, the next Nurse Hack for Health virtual hackathon is November 13th through 15th and focused on pandemic management. Wondering what other hackathons are out there? Check out Major League Hacking at mlh.io, where you'll find topics, times, and tribes where you can invest your energy, talent, and unique point of view in solving some of society's greatest challenges. If you care about it, there's a hackathon addressing it. For See You Now, I'm Shauna Butler. Thanks for listening.
Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance healthcare for all. Subscribe to the podcast and learn more at seeyounowpodcast.com.